So in our last lecture, we focused on using our ultrasound skills to examine the left heart function and specifically emphasized classifying the left ventricular ejection fraction as either normal or reduced. But we know that there's also a variety of acute and chronic conditions which can affect the right side of the heart as well. And so the purpose of this lesson is to identify some of the evidence seen on ultrasound that supports the diagnosis of right heart strain. We ended our last lesson with this case, which I'm going to bring up again just so that we can emphasize why this might be useful. If you remember this case, we had a 35-year-old female who was admitted to the ICU during the COVID pandemic, ventilated for acute hypoxic respiratory failure with an elevated blood gas of carbon dioxide. And basically, the question was there some left heart disease because she had some edema and volume overload on her exam. And after doing an EPSS, which it pops up here, it looks like everything on the left heart was going pretty well. Maybe a little bit hyperdynamic, but overall, there's not evidence of left heart disease going on right now, at least. So the clinical question that then was raised is, could there be right heart disease or right heart strain causing this clinical presentation? And what we'll come to learn in this lesson is that there's a constellation of findings that are sometimes seen in right heart failure, but that not one finding is pathognomonic for disease. For this reason, we have to look at multiple possible signs of anatomic or functional changes of the right heart, and that helps us increase our detection rates for pathology. Like I mentioned, we can assess the right heart using a variety of different methods. Some of these include comparing the size of the right ventricle to the left, and particularly how they might dilate in response to increased pressures on the right side of the heart. The appearance of the wall and the interventricular septum can also help infer about the pressures sustained on the right side of the heart, and in turn, this can cause changes in the systolic contractions that we can measure. Putting all of this together, we can sometimes even estimate an actual number for the right ventricular systolic pressure, which should approximate the pulmonary artery or capillary wedge pressure, but it's not as invasive as a right heart cath is to get us that answer. Let's review a bit about our anatomy before we start diving in. This cartoon on the left isn't completely accurate, but it does demonstrate a couple of important points. The first is that when we compare it to the left ventricle, the right ventricle is typically more anterior, has thinner walls, and wraps around the left heart and septum without disrupting the anatomy of these higher pressure chambers. Additionally, this is the best clip that I've found online to help demonstrate a key point, which is that the right ventricle contracts in a very different way than the left ventricle contracts. When we think about the left ventricle, we know it contracts concentrically or radially, which, if you can imagine in our peristernal short axis view, remember how we saw that nice circular myocardium and it just contracted towards the center and the walls thickened? So that's a radial contraction pattern. And while the right ventricle does have some radial components, the majority of its contraction is longitudinal, means that this right ventricle shortens during systole. And this will come in handy for some of our measurements that we'll take a look at later. Another anatomical finding that can sometimes be seen in the right ventricle is a fibrous band of connective tissue in the right ventricular apex, which is the moderator band, and helps conduct electricity across the heart so that the heart can contract in a uniform pattern. Here we can also see this moderator band on a prosection. Let's start off by reviewing some of the normal anatomy that we see as seen on ultrasound. So you should recognize this view. This is a peristernal long axis view of the heart. And I've darkened our optimal imaging checklist here at the top, but you can see that from our previous lecture so that you know this is a peristernal long axis view and it's an optimal view. And when we look at the right ventricle on the peristernal long axis view, our rule of thumb is that it should be about the same size and diameter as the aortic outflow and the left atrium. And we call this the rule of thirds. So here I can highlight the right ventricle in yellow, the aortic outflow tract in purple, and the left atrium in green. And as you can see, they're all roughly the same size. This helps us know that the right ventricle is not massively dilated because it does not violate this rule of thirds. If we move to the parasternal short axis view, we can see the crescent-shaped right ventricle sitting over the left ventricle. And here we see a nice circular left ventricle, and the intraventricular septum is not being flattened out. And then when it goes away, you see it's nice and circular. This right ventricle isn't pushing on this intraventricular septum at all, so that's a normal finding. The apical four-chamber view gives us the best side-by-side comparison of these two chambers. In this view, hopefully you can appreciate that the right ventricle should be smaller, roughly less than 2/3 the size of the LV. Now it can vary, it can be about 1/3, it can be about half the size, but it shouldn't be more than 2/3 of the size of this left ventricle over here. We also see an example of how the tricuspid annulus down here, this bright shiny band of the tricuspid valve, the label's a little bit off there, should move during systole because this ventricle is contracting by shortening more than it is moving into the center, contracting radially. We can also see the moderator band up here in the right ventricular apex, all signs of normal anatomy. And here we just see the right ventricle and left ventricle. And like I said, it should be less than 2/3 the size of the left ventricle. Now, this is affected by probe rotation, so it's important that you see both the tricuspid and the mitral valves in the same plane to not overestimate or underestimate the size of the right ventricle. Now that we've seen some examples of normal right heart anatomy, let's go over how some of these changes might occur in the right heart strain. This stair-step flowchart shows us what some of these findings might be. So there's a few ways that the right heart can be insulted. Common things we think about are the backup of blood in the pulmonary vasculature, which can happen in left heart disease, or pulmonary hypertension, which could be due to a variety of different lung diseases, or even an acute blockage of the pulmonary vasculature due to a pulmonary embolus. Additionally, trauma or ischemia to the right heart myocardium can also cause the right heart function to be affected. But any of these insults basically cause the right ventricle to pump ineffectively, which begins to cause the blood to back up into the right heart and in turn increases the pressure inside the right ventricle. As a result, we start to see the right ventricle and the right atrium dilate in response to these higher pressures. If this is an acute insult, the myocardium will still appear thin, but if this is a chronic insult over time, that right ventricle will start to hypertrophy in response to the chronically elevated pressures and have a thicker wall. As the dilation occurs, the systolic function is also affected to an even greater degree. Eventually, the tricuspid valve will be stretched open and regurgitation will occur, which further decreases the injection fraction. If the right heart pressures begin to approximate or even exceed the pressures generated in the left side of the heart, that intraventricular septum can start to bow or flatten, and that will distort the anatomy and the function of the left side of the heart as well. Let's start to look at some abnormal findings. So here we have a static image in the parasternal long axis view where we can see that the right ventricle is quite dilated up here. If you recall that in this view, a normal right ventricle size should be roughly equal to the size of the aortic outflow tract and the left atrium, which we call the rule of thirds, you can see here that this right ventricle is clearly violating this rule. Here are some examples of how the right heart can dilate and even take over the apex of a typical apical four-chamber view. As the ventricle dilates, it begins to take up more and more of the space at the apex, eventually becoming the predominant chamber. If we rotate our probe into the parasternal short axis view, we can clearly see when the right heart pressures exceed the left heart pressures. So in the image on the left, we see that there's a nice circular intraventricular septum that's not being affected by the right heart at all. But in the image on the right, which is actually from the same case that I presented to you at the beginning of this lesson, we can see that this intraventricular septum is flattened. It's not nice and circular like we would expect. It's actually being cut in sort of a cross-section into a D shape. And so here's an O, and there's a D. And this is a positive D sign, is what some people will call this, but it's evidence of elevated right ventricular pressure. And indeed, this patient has severe pulmonary hypertension that's resulted in right ventricular hypertrophy and certainly a flattening of her septum. Going over the findings we've reviewed so far, they collectively only have a moderate sensitivity and specificity for right heart strain. Why so low? Well, this is a relatively newer application of point-of-care ultrasound, and so it is less studied than perhaps the left side of the heart for a point-of-care exam. It's also more complex measurements, so oftentimes these require multiple views of the heart, requiring difficult windows to obtain, a lot of times using our apical 4-chamber views or even apical 2-chamber views, things that I haven't taught you how to do. And that can be a challenging, technically complex exam to perform. And then lastly, there's a broad differential of etiologies that can contribute and affect the heart in a slightly different way, which really impacts the specificity of these findings. Now, there are a couple of assessment methods that we haven't quite covered yet that may be a bit better, that have a little bit better evidence behind them. Those are called the TAPSE and spectral Doppler interrogation, and we're going to go over those over the next couple of slides. The first of these more sensitive methods that I want you to know about and that I want you to start practice performing in hospitalized patients or in our POCUS clinic is called the tricuspid annular plane of systolic excursion, or TAPSE for short. TAPSE is also going to be on my list of potential dog names if Doppler ever gets a little sister. So recall how I emphasized that the right ventricle contracts in a complex way, but that it has a predominant component of longitudinal contraction, which basically means it gets shorter during systole. If we measure the tricuspid annular plane of systolic excursion, we're taking advantage of that knowledge, and I'll show you how on the next slide. To measure the TAPSE, we're going to use our good old friend M-mode. Remember, M-mode traces one slice of an image, which we'll indicate here with this red line, and projects the movement of that line as a function of time. For this measurement, we're going to position our M-mode cursor over the lateral edge of the hyperechoic tricuspid annulus in the apical 4-chamber view. This measurement is predicated on obtaining an accurate 4-chamber view, so if you need practice reviewing how to do that, go back to the first lesson in this module for a review. When traced over time, we can see that the tricuspid annulus moves substantially in a normal patient as the ventricle contracts. The TAPSE is obtained by measuring the maximum distance traveled by the valve annulus during the cardiac cycle. A normal heart will show the annulus traversing at least 2 centimeters or 20 millimeters during the contraction of the right ventricle. Meanwhile, an excursion of less than 17 millimeters is suggestive of right heart strain. Here's a summary of some of the evidence that supports using TAPSE as a measurement of right heart strain. Based on incident data, the right heart strain, which can be defined as either echocardiograph findings, troponin elevation, or EKG changes, will occur in up to 60% of patients who suffer from an acute pulmonary embolus. When TAPSE is used to investigate the heart in a patient with a suspected PE, a TAPSE less than 17 millimeters has a positive likelihood ratio of 2.6. The sensitivity is reduced somewhat by other etiologies like pulmonary hypertension or left heart disease, which can also affect right heart strain, but it's still a great tool to have in your toolkit to assess patients. I find myself using the TAPSE in patients that may be in the ICU and they have abrupt decompensation for some reason, and they're not quite stable enough to go down to radiology and get a CTPE, or perhaps their kidneys won't tolerate the contrast load of a CTPE, that maybe we don't have a VQ scan available, and that we're trying to make that decision about whether or not to anticoagulate them or get IR or someone involved for a thrombectomy. That is kind of, I think, one of the benefits of this TAPSE. It's also the least operator-dependent measurement, meaning that it's the least subjective and most objective measurement that we take, which gives us some pretty good reproducibility. Lastly, I want to introduce you to spectral Doppler interrogation of the right heart. This is an advanced skill that I don't expect you to know how to perform, how to use the machine to actually calculate all of this, because it's pretty complex. It's something that we can definitely go over if you do an ultrasound elective with me. But basically, I want you to be able to understand how to interpret these findings for your patients. At its core, this method uses Doppler measurements, which looks at the velocity of blood flow and calculates using some formulas in the machine and modified Bernoulli equation that correlates the velocity of the flow to the pressure gradient on both sides of that flow. And in certain scenarios, it can be over 90% specific for an acute pulmonary embolus, which could be super helpful in an acutely ill patient. So the basics of how to use a spectral Doppler to look at the right ventricular systolic pressure exists because we know that the typical right heart will dilate in response to elevated pressures. And with this dilation, the spreading of the tricuspid valve annulus will result in tricuspid regurgitation, which we can see here on color Doppler flow. So if you look, there's these sort of alternating kind of blue lines of flow coming back into the ventricle or back into the atrium during systole, which is evidence of a tricuspid regurgitation jet. And what we can do is use Doppler mode to actually measure the velocities that are occurring in that tricuspid regurgitation. And there's a complex pattern called the Bernoulli equation that can take that velocity and give to us a pressure. And when we calculate that pressure, we know that there's a difference in pressure between the right ventricle and the right atrium of that amount of that flow. And then what we can do is estimate the central venous pressure, which should be equivalent to the right atrial pressure, and add those together to get an overall right ventricular systolic pressure. So basically, it's a way of getting a right heart cath without having to ever stick your patient. It's not quite as accurate since it is inferred by a couple of calculations, but studies have shown that it is, comparable to getting a Swan-Ganz catheter on your patient and estimating the right heart pressure that way. So in review, we used this lesson to talk about the normal right heart anatomy and function, and talked about some of the windows that we have to utilize to evaluate the right heart, most notably our apical four-chamber view and the parasternal short axis view. We then looked at some of the acute and chronic causes of right heart failure, including right ventricular dilation, apical dominance, and using the TAPSE and Doppler skills to further assess this side of the heart. We're going to have one more lesson that will talk about some of the other findings we can see in cardiac pathology, and then that'll be it for our module on cardiac POCUS. We'll see you then.